Welcome to this morning's Thyroid Tumor Board. We have a wonderful cast of characters to help us today with the cases. As you know, we do these on a regular basis each month and have cases presented from all around the world and get experts from around the world to sort of think through and discuss how we would take care of these cases. One other thing I will call your attention to on the next slide is the Voices of Wisdom. This is a series of podcasts that Tyro's put together. I'm particularly proud of these. These are really good, in my totally unbiased opinion. Short 10 or 15-minute snippets of really important clinical management issues in thyroid cancer that you can find easily on on Spotify and on the Apple Podcast and all over on the links. Next slide. So this morning we have a wonderful tumor board. I'm Mike Tuttle. I'm one of the endocrinologists and thyroid cancer folks from Memorial Sloan Kettering in New York. I'm going to go around the circle and have folks introduce themselves. We'll just start with Mark. Dr. Zafereo.
Hi, I'm Mark Zafereo. I'm a head and neck surgeon at MD Anderson Cancer Center.
Dr. Langer.
Hi, Jill Langer. I'm a radiologist at University of Pennsylvania.
Perfect. Dr. Brito.
JP Brito, endocrinologist at Mayo Clinic.
And our newest and most outstanding member, Dr. Iñiguez.
Hi, I'm Nicole. I'm a thyroidologist from Mexico City and practicing as an oncologic endocrinologist, caring for thyroid cancer patients.
Fantastic. Dr. Brandwein.
Hi, Margaret Brandwein-Weber. I'm a head and neck pathologist. I'm chief of service at Mount Sinai West. I run a head and neck pathology fellowship, and I work with Mark.
You poor thing. Dr. Rossleigh, middle of the night.
The other Mark. The other Mark.
Oh, the other Mark.
The other Mark.
Hi, I'm Monica Rossleigh. I'm a nuclear medicine physician and I work at Prince of Wales and Sydney Children's Hospital in Australia.
We got Dr. Zafereo for no good reason. Dr. Cheng, introduce yourself for me, please.
Yeah, I'm Leslie Cheng. I'm one of the clinical oncology residents at the Royal Marsden Hospital in the UK.
Fantastic. Welcome, Leslie. Glad to have you with us. And Dr. Newbold, we'll let you introduce yourself and we'll bring up your first slide while we're introducing you.
Thank you very much, Mike. So I'm Kate Newbold. I'm one of the head and neck and thyroid oncologists at the Royal Marsden in London. And we are delighted to be able to discuss some hypothetical cases with you in the meeting today. We hope that today we hope that we have put together a combination of cases that highlight some particular issues that we come across fairly regularly in the clinic. And we are concentrating today on patients who have tumors with RET alterations.
And Kate, I saw Dan sign on here. Dan, flip your camera on and just join us here if you want to, if you're in a place where you can turn the camera on. So I got you, Dr. Marganstein. There you go.
Yeah, but afraid my camera's not working.
Oh, okay. Well, and so Dan, just introduce yourself and stay with us on here.
Yeah, hi, I'm Daniel Marganstein. I'm a consultant endocrinologist at the Royal Marsden and Chelsea and Westminster Hospitals in London.
Awesome. That's fantastic, Dan. All right, Kate, let's do this.
So the first case that I want to discuss is a 50-year-old gentleman. He presented with a really quite rapid history, a 3-month history of a neck lump that was growing and the development of hoarseness of his voice. He had very little past medical history, some hypertension on a low dose of ramipril. He's a postman, so fairly active. Ex-smoker 20 years ago with a less than 10 pack year history and no significant family history. Next slide, please. So investigations in the outpatients with flexible nasendoscopy revealed an immobile fixed right vocal cord. Went on to have an ultrasound scan of the neck, which showed a large multinodular goiter, but there was some suspicion of this not being a benign process with involvement of the strap muscles, particularly on the right side. The mass was extending posteriorly into the tracheoesophageal groove, and there were pathological lymph nodes on ultrasound in the right neck, throughout the right neck, levels 3 down to central compartment 6. And the ultrasound grading of the thyroid lesions was a U5 in UK, which is equivalent of a TIRADS 5.
Dr. Zafereo, from the 30,000 feet view, lots of lymph nodes, lots of nodules in the thyroid, assuming this is thyroid cancer, paralyzed vocal cord. But what are you sort of thinking now in terms of where we are, imaging, staging, as a surgeon? Where are you sit on this, Mark?
Yeah, I think as you mentioned, we have a 6 centimeter tumor. We have a vocal cord paralysis. We have a lot of lymph nodes. So we don't know anything about the pathology, but we're assuming thyroid cancer, and I mean the most common being a differentiated thyroid cancer. But if it is differentiated, it's probably along that more aggressive scale of differentiated thyroid cancer that's behaving badly, or it could be something that's de-differentiated a little bit. So I think we'd want to get CT neck and chest imaging, and we may even consider a PET scan too, because a lot of these tumors that are more biologically aggressive, bad behaving, are PET avid. So those would be the imaging studies I would be looking at to try to further evaluate this patient.
Perfect. All right. And Kate, where'd you guys go?
Next slide, please. So we did do a CT, or the patient did have a contrast-enhanced CT scan of the neck and thorax, and this confirmed the extent of the mass arising from the right side of the thyroid, extracapsular extension involving that esophageal groove and extending down to the sternal notch and just into the superior mediastinum. The right levels 2 to 4 and 6 nodes were involved, but there was no evidence of any distant metastases within the thorax. Next, if you just click again, please.
Hold on a second there. Jill, in terms of, we had this ultrasound to begin with that had all these lymph nodes. CT, MRI of the neck, is there any preference one versus the other? Looking at airway and sort of planning surgical stuff, Jill?
Yeah, I think probably CT would be very good, particularly at what sounds like an aggressive tumor. It'll give you a better look at the trachea. When you're starting to see multiple nodes extending low, that nodes are likely present outside the sonographic field of view. So I completely agree with Mark that CT of the neck and chest would be indicated.
And JP, any concerns with doing CT with contrast? Because this is going to be thyroid cancer. Radioactive iodine is going to come into this discussion somewhere. We used to worry a lot before you were born and I was trained. Where are you sort of thinking now, JP?
Now that that for us is really not a concern. I think we are dealing with something of an aggressive behavior here, and likely in our minds is mostly to give Mark and the surgeons a good imaging for them to decide whether we can operate. So at this point, radioactive iodine is not our main concern.
And Monica, indications for PET scan kind of up front. Mark sort of hinted this was growing, it was invasive. We don't normally do PET scans with upfront imaging and staging, but where would you use that?
I think, as Mark said, if you've got a suspicion that this is highly aggressive disease, de-differentiated disease, then that's when you would consider a PET CT. Yeah. With FDG.
FDG PET, that's right. You guys have so many PET CTs now, we have to specify, right? So.
Yeah, exactly.
Okay,
that's
cool.
the glucose.
Okay, good. All right, and keep going there for us, Kate.
Yeah, so this was an FDG PET CT that we did because of the aggressive nature of the tumor. And there was nothing outside of what had already been highlighted with the ultrasound and the CT scan. Next click, please, Sabrina. So we were staging this clinically as a T3B, N1B, but an M0 disease. Next click, please. So went ahead with a fine needle aspirate, and this revealed papillary thyroid carcinoma from the thyroid mass, but with some focal de-differentiation. And there was papillary thyroid carcinoma confirmed in the right lateral and the central compartment lymph nodes as well.
Now, Margie, I know you continually remind me you're not a cytologist, but just at least tell me what that de-differentiation terms mean, even outside of cytology.
Sure. So what I would want to know in greater detail is what do you mean by the de-differentiation? They could be referring to necrosis or mitotic activity, and so now the term so that could be one possibility, and so now the term would be high grade differentiated thyroid carcinoma. So that replaces the tumor formerly known as poorly diff, or they could mean a progression in pleomorphism, and actually what may be implied here is like progression to anaplastic thyroid carcinoma. So I'm thinking that any of those possibilities are, and certainly it makes sense because, to think that this presentation is merely PTC, I think is a little naive.
Right. So
could be, unless everything else, once everything else is excluded.
Could I ask something?
Yeah.
What is the threshold, for instance, Margaret, of you preferring fine needle aspiration biopsies versus core biopsies for something like this? So in my mind, as the case was presented, I was thinking this looks more like a core biopsy kind of decision rather than fine needle aspiration biopsy. What is the preferences from the pathologic perspective? Would you prefer having a sample as a core biopsy or fine needle aspiration?
Sorry, who's the question? To me?
So no, yes, to you, Margaret. So in terms of yes.
Sure. Well, I'll tell you, there are some issues with FNA that, like immuno might not be as reliable on FNA as it is on core biopsy. So if you were looking for if you want to get BRAF on rapid BRAF on immuno, it might be better to do it. I have no idea how it works on cytology, but as a general rule, it's more reliable on core biopsy. So, as a non-cytologist, I'll always say that a core biopsy is preferable.
Mm-hmm. That sounds good. Okay, let's keep going.
Next click, please, Sabrina. So this patient went for a multidisciplinary discussion in their center, and the plan was for a total thyroidectomy and a right neck dissection. Next click, please. But on prior to the admission, the patient, this gentleman he just developed some discomfort in the neck. He'd had some discomfort in the neck already, but then just described feeling a little bit dizzy and some headaches, which admittedly had been thought to be all related to the bulk of disease within the neck. But for completeness, some brain imaging was done.
Yeah.
And an MRI scan, and a next click as well, please. An MRI scan revealed 3 deposits or abnormalities within the brain, which were suspicious for metastatic disease. 2 in the right parietal, 1 in the right parietal lesion, which was the largest at around 2 centimeters, and there was some perilesional edema there, and then 2 sub-centimeter occipital deposits.
Okay, Nicole, this case just took a left turn. So we went from this is going to be Mark's problem, lots of disease in the neck, that sort of stuff. Now, even brain metastasis in particular, but if you'd have found lung mets or spine mets, how does that presence of distant metastasis make you think about the case now, Nicole?
I mean, I think the case is aggressive from the beginning because it presented with a right vocal cord paralysis, but now it's become way more aggressive with symptomatic brain mets. So I'm really concerned with this case, and I wonder if this progression is been so fast that we could consider in the differential anaplastic thyroid cancer and on unbiased sample,
Yeah, because that was kind of worrying JP as well. That's sort of the whole discussion about core versus fine needle aspiration. All right, JP, we've got brain mets here of something. We got lumps in the brain. So how do you sort of next step here? How do you figure this out? Is this thyroid cancer? Do we have to think about other tumors? How are you thinking about this, JP?
Well, is the PET scan did not reveal any other tumors outside the neck. Of course, the PET scan missed this one because the PET is completely, yellow on the image. So this, of course, was missed. Likely it is the thyroid cancer, either fully differentiated or anaplastic. It's worrisome because you are dealing with an invasive disease in the neck. Now you have metastasis in the brain. And the rule is to treat the one that's going to, unfortunately, kill the patient if you don't. So in this setting, I think you have to focus on the brain metastasis. Likely to do some decrease in swelling, maybe with the steroids, and then decide next step. But brain metastasis takes priority.
Okay. Sabrina, go to the next slide for me.
Can I just say that with FDG PET, brain is an area where we may miss metastases because of the normal background uptake of glucose in the brain. So if there's any suspicion, then you do need to do brain imaging.
Yeah, and Monica, routinely at our place, the FDG PETs for thyroid cancer start at basically the ears and go down. We don't even look at the brain. Do you normally encompass the brain when you do a straight FDG PET?
We do. We go from vertex to thighs, but I know a lot of places go from eyes to thighs and
Kate,
don't even look at the brain.
Kate, you guys do?
Yeah, we do vertex to mid-thigh. Yeah,
I got you. Okay, so next slide, because Kate's got a few questions on for us here. Mark, help me think through this a little bit, because remember she got a vocal cord paralysis. She's got invasive disease in the neck. You couldn't see the CT scan, but normally you say definitely do the brain first, but sometimes there's an airway thing. So how do you sort of think through this, Mark?
That's a good point. I think we want to study the images, and also obviously if the patient had any symptoms in terms of breathing difficulties, we'd get a little bit of idea of the vocal cord situation from the scope. It sounds like this patient has unilateral paralysis, which is not an emergency, but we would want to just double check the CT scan, make sure there wasn't significant tracheal involvement, compression, but usually that patient would be symptomatic. So I would agree with Dr. Brito's assessment that we would really focus on the brain, probably with steroids and radiation, and then see what's happening in the neck after that.
Let me ask both Nicole and Kate. When this comes up at our place, the question is always, are we certain this is thyroid cancer in the brain? And so if it's single places, we often just resect it. Multiple places may not. Sometimes we'll do a biopsy. Nicole, what's sort of, I guess, if there is standard practice for brain metastasis, would you guys lean toward just assuming, or do you biopsy, or case by case?
I mean, I would think in this particular case that we have a very clear primary tumor. I would think we would not biopsy. We would consider it aggressive thyroid cancer. It could be poorly serrated or anaplastic, but we wouldn't do a biopsy because it's consistent with an aggressive thyroid primary tumor.
I think that's what we would do because the PET scan didn't show anything. Kate, how did you guys sort of think?
Well, I think that we would often go for a biopsy if it wasn't clear. The issue here in we've had a couple of cases like this, and the issue has been that there's been quite rapid progression within the neck that we are concerned about the compromise for airway, for example. And therefore, if you go down the surgical route for biopsy, you potentially prolong that period before you can then tackle the rest of the disease. Whereas, I mean, it does depend. I mean, if you go towards stereotactic radiosurgery or stereotactic radiotherapy, then there is some preparation for that, and you need to also be fairly sure that you can get onto that treatment fairly quickly. So it's a balance with the potential deterioration in the rest of the disease whilst you deal with the brain. If it was a solitary lesion, we'd be more concerned about trying to get a biopsy. Our neuro-oncologists and neuroradiologists now are very good at kind of giving us a steer as to whether they feel this is a metastasis or a primary within the brain. So it's definitely it highlights the importance of the multidisciplinary discussion in these situations.
Yeah, we're the same kid. Our neuroradiologists really give us a good hint about whether it's primary or not. Okay, let's go ahead and see what happens with the next sort of issues here. Go ahead.
So in this, for this gentleman, it was difficult to know whether his symptoms were related to the fairly small lesions, but however, they worked in the sense that they kind of triggered the investigation and they triggered the finding of the disease. But we opted that he was going to go for to have the brain lesions dealt with in the first instance. He was on some symptomatic dexamethasone just in case that was what was causing the headaches, and actually did get some benefit, but also some benefit from the neck discomfort as well. Next click, please. So alongside this, whilst the neuro-oncologists were working him up, we also recommended, because we'd only had an FNA to date, that this patient did undergo, as we've discussed, a core biopsy for definitive pathology, and also to expedite some molecular profiling at the same time. So the neuro-oncology team did discuss the possibility of surgical approach. This would require 2 craniotomies because of the different sites of disease. And actually, overall discussion, we recommended the patient to go for SRS. Okay, next click, please. And again. So the core biopsy did show, we were wondering whether this was anaplastic, but it didn't show anaplastic. But it did show differentiated high-grade thyroid carcinoma, as already predicted. And next click, please. And we also got the molecular panel back, which showed a RET fusion. It showed a TERT promoter variant and a TP53 variant, and no other variants in any other actionable sites.
Yep, so consistent with a more aggressive genotype and phenotype. This goes along with the story, right? You got a RET C mutation, you got TERT, you got P53. So as Nicole said, from the very beginning of this case, there were red flags if this was more aggressive. Okay, and then where do we go from there?
So the patient, he did remarkably well. He recovered very well, but whilst he was recovering from the neuroradiology, he felt more pressure in the neck, and we re-imaged, and this showed that there had been fairly significant progression. The tumor was invading through the trachea, and there was development of multiple, albeit small volume, but multiple lesions within the lungs.
All right, Mark, help us out here now. So we've got this bad disease in the neck. It's growing into everything. Where are we with RET inhibitors? And we call this neoadjuvant setting therapy right now. Talk to us a little bit about that.
Well, yeah, this is an unfortunate and very obviously challenging case. I think certainly it sounds like that the tumor has progressed to the extent that surgery would either be unresectable or significantly morbid surgery. And of course, in the setting of distant disease, including brain mets and now what seems like small progressing lung mets, we wouldn't want to do a significant surgery for this gentleman. So we're obviously thinking, control the airway. So with this progression, we have to sort of evaluate with the CT imaging and with the patient's symptoms. Do we think this patient needs a tracheostomy, at least temporarily, to kind of allow him to continue to breathe well and to get through treatment? So that would be my first task, would be to really talk to the patient about his breathing, study the imaging, and discern if he needs a tracheostomy tube. And then, secondly, I think this is a systemic therapy issue. Unclear if this patient will ever, have surgery. This is behaving so aggressive systemically that, obviously the patient needs to start on systemic therapy with, as you mentioned, probably first line would be a RET specific inhibitor. But it's unclear if he'll ever have surgery. It certainly will depend on, his response and particularly if he remains controlled distantly, whether or not we'd ever be able to do a surgery. Certainly a pretty unusual mutational burden for a patient with a RET fusion, to see also the P53 and the TERT. So a little bit unclear how this patient's going to respond to a RET inhibitor. May not respond, as well as classically.
Nicole, you practice in Mexico. What can you get sort of the somatic germline testing? What do those panels look like, and the availability of some of these targeted therapies for your patients?
So we can get an NGS, but we do send it to the US to get an NGS. We have like smaller panels with like few genes or genomic alterations. We do have MKIs, but and we have BRAF and and MEK inhibitors. We don't have yet the selective RET inhibitors, but we're eagerly waiting for them. But yeah, so that's.
Nicole, may I ask you, what's your turnaround time when you're sending these tests out to the US?
Yeah, it takes like 10 days.
That's actually pretty good.
Oh, okay.
I don't think it takes any shorter time if we're sending it out also. So that's not so bad.
Yeah.
And Kate, the situation in England for next generation sequencing and these targeted therapies?
Yeah, we're lucky. We have availability throughout England for the testing. The turnaround time, however, just because of capacity now, is around 2 weeks. Yeah. We can get some quicker. So, for example, BRAF for anaplastics, we can turn around more quickly. They'd say 48 hours. It's not quite our experience, but we do get immunohistochemistry for BRAF as well to speed up the implementation of BRAF-directed therapies.
Yeah, and as long as I'm going around the world, JP, let me put you on the spot. You know what the situation is in Ecuador, Central America, those sorts of areas?
Yeah, I don't think they have the ability to send the samples to the United States that easily. Some about politics and that kind of stuff, but I think they do have a panel, but it's very focused on specific mutations, BRAF mostly, and they use one in South America, but I don't think they send the sample to the United States very frequently.
Not as easy.
And also it's quite expensive, it's extremely expensive.
Exactly, yeah. And Monica, in Australia, you guys have pretty easy access to NGS.
We have access, but as JP said, the money side of it is the issue, because we do have government medically funded health, but they're not funding gene sequencing yet. So it's a cost to the patient.
Gotcha. Worldwide. Okay, Kate, go ahead and let's see what happened to this person.
So these were the discussion points, particularly, now we have an actionable target. The disease we didn't feel was operable or appropriate for operation. That we did assess the airway. The airway was felt to be safe, and our head and neck surgeons did not feel the patient would need any intervention at this point. So we'll start systemic therapy with this patient, with selpercatinib, which is available to us now, just turned available to us as first line. Previously, it was second line, but now first line. Next slide, please. So we would always start at the 160 milligrams according to weight, obviously. The patient did develop some toxicities with grade 2 hypertension, some constipation, and some peripheral edema, which are the typical trio of side effects that we see with selpercatinib, although actually hypertension doesn't seem to be such a big side effect as we see with our multikinase inhibitors with the VEGF activity. So actually we interrupted it, got him on to further antihypertensive. As you remember, he was a baseline ramipril, and blood pressure is controlled, and selpercatinib recommenced at the first dose reduction of 120 milligrams twice a day. And next slide, please. There's been a good response, but I had Mark's concerns as well as to whether this was purely driven by the RET fusion. However, we are seeing good response in all sites. The drug is being tolerated well and symptomatically better. So we keep, fingers crossed that this is the driver of the disease, and that we'll continue to have some response.
Nicole, let me ask you, not in this particular hypothetical case, if I take the TERT away and I take the P53 away, because who knows how that's going to affect outcomes and that sort of stuff. If it's just the straight red PTC mutation, you put somebody on selpercatinib, how long do you tell the patient that's likely to last? A year, 2 years, 5 years? We don't know. I mean, gut feeling. What do you tell folks about that?
I mean, I would tell them that they do have a good they do respond well for many months, even years. So I would say it's different to other kinase inhibitors and is well tolerated. So I would probably tell them that.
Yeah, it's there. Okay, let's go to the last slide and make sure we got all the teaching points here, Kate. So I think we talked about the differentiated high-grade tumors. We talked about the red fusions, how this one might be different because, as Mark said, they got the P53 and the TERT on top of it. A little unusual for all the red fusions that we see. I think the natural history of this on the first slide, people were already starting to tell us it was dedifferentiated, and Margie was pointing that out, and JP was wanting a core biopsy, right? So there were flags from the very beginning of this one. We talked about the management of brain metastasis. And Kate, I swear to God, I don't understand this concern about blood-brain barrier in these Mets because there's tons of edema around these things. How good is the blood-brain barrier around these? I know there's always concern where these drugs will work, but I struggle to understand if the blood-brain barrier is really there when you have all that edema around it.
I agree. I mean, I think once you've got disease there, that's disrupted, isn't it? Anyway, and then on top of that, if you irradiate, but the evidence from the lung cancer arena is that actually there is good penetration of selpercatinib for the lung cancer that are RET altered into the cerebral tissue. So, we would expect that patients with disease such as this example would also have benefit from the drug therapy as well as the locally ablative therapy.
Awesome. Fantastic. All right, let's go to case 2. We'll stay on our same RET theme here, but a little different variation on this one. Kate, what do you have for us here?
So this we go to a different demographic. So this example is a 34-year-old female, presents with noted some lumps within the neck over, she reports 3 months, but also when you ask direct questions, some sort of systemic symptoms over a longer period, perhaps over the last 18 months with loose stools and bloating and some weight loss. And that history of IBS, has been intermittent prior to that, but particularly more consistently over the recent year. No drug history, no family history of note.
Yeah, and I can't resist because every endocrine board review course, if you see thyroid cancer with diarrhea, it's supposed to ring the bells of medullary, right? That's and when you go back and take these histories on these guys, it's often not a history of IBF. It's a history of progressive loose stools over the years. So that diarrhea plus nodules is supposed to ring the bells. JP, you were going to say? I saw you flip on there.
No. I'm just saying that if I were to see this case, I know that we're talking about RET mutated cancers, but in general, I wouldn't. It could be a viral infection, or could be worsening of symptoms, could be something else. Yeah, but I know where this is going.
Absolutely. Okay, Kate, keep going.
Okay, next slide, please. Thank you. So the patient had investigations initially with an ultrasound locally, and then ongoing with an MRI neck and a CT thorax after a thyroid mass and potential lymph nodes had been identified. And the anatomical imaging of the neck did show a right-sided thyroid nodule and multiple pathological lymph nodes throughout the right neck from level 2 down to level 4 and also into level 6 central compartment. And this time again, a fine needle aspiration was performed, and the cytology from the thyroid tumor and the lymph nodes revealed medullary thyroid cancer. Sabrina, next slide, and again, please. And so a serum calcitonin was taken, and this was around 13,000. And next.
So Mark, talk me through this sort of, years ago, the operation here was going to be total thyroidectomy, central bilateral neck. And now over the last 10 or 15 years, with really good imaging done at your place, if there's really nothing on that left-hand side, how are you making that decision about prophylactic on the left? Obviously, you're taking out the disease on the right and the central, but talk us a little bit how that's maybe changed over the last few years. Oh, you're on. I can't hear you, Mark. No, you're not on mute. Yeah, are you got another set of headsets or something on? Yep, I'm not hearing you.
Come back to me.
Okay. Oh, I just heard you there. You just said come back.
You hear me? You hear me?
Yep,
Okay.
I got you. I got you.
I
Yep.
apologize. I apologize. I'm not sure what technically happened there, but if you lose me again, let me know. So yeah, you're exactly right. I think that the studies have shown, and the thinking sort of has evolved over the last decade to 10 to 15 years. As we've sort of become a little bit more conservative with surgery and differentiated thyroid cancer, medullary thyroid cancer being a different disease, but this is an example of how the surgery has become a little bit more more conservative. Where I think at a lot of centers, I don't think that this is universal yet. I think there still is some controversy, but at a lot of centers, we are just operating in terms of lateral neck disease. When we take the thyroid out, we're still doing the central compartment dissection because we're already there. But in terms of the lateral neck disease, we're essentially operating if there's disease in the lateral neck. So if you've got unilateral disease that's evident on radiographic imaging, good ultrasounds and CT imaging, you'll do it. But if you don't, no matter what the calcitonin level is, in this case 13,000, then you'll leave that neck alone, realizing that you can save it for another day if disease does come up in that neck later. So that's I think the way a lot of the field is thinking.
As we've transitioned, Dr. Erkin or Dr. Shaha, can one of you guys flip your camera on for me? Are you guys paying attention? Like one of you guys? Maybe they got to be one of them. There you go. Hey, Ishak. Yeah, there we go.
Yeah.
There. Mark and Ishak, if I push this even farther, so if you have a small medullary confined just to the right lobe, right? So we're doing less prophylactic neck dissection, and now behind the scenes, I hear a lot of people talking about not even doing a total thyroidectomy up front for medullary that's small and confined. Ashok and then Mark, where are we on that? And are we really thinking about lobectomies for medullary at this point? Dr. Shah?
I think, for genetic, like a sporadic medullary thyroid cancer, there's a lot of evidence now in doing only lobectomy and following the calcitonin. Calcitonin is a great marker. So we could follow the calcitonin and the opposite lobe, if it is normal with ultrasound. I think it is very appropriate to take out only one lobe to give the best quality of life.
Yeah. So
I think
so
we are now integrating the quality of life in the whole equation, which we never did before.
Yeah. So Mark, we know, and even in sporadic medullary, it can be multifocal. They can have some disease on the other side. Where are you now, like in your personal practice, doing total or thinking about a lobe for medullary, Mark?
Yeah, I think I agree with everything that's been said. The one thing I would add is what the nodal burden is in the central compartment. If you've got pretracheal, prelaryngeal, and you've got a ton of nodes, I don't feel comfortable not addressing the other side. And so that's really the issue. If you've got a lower burden and you've got a great ultrasonographer telling you there's nothing in the other lobe, I think you can make an argument with the caveat that I just mentioned.
Yeah. Last one, Dr. Zafereo, where are you on lobectomy for medullary before I move on? Oh, I think you're muted again for some reason. Maybe it'll pop back on.
Are you able to hear me now?
Yep.
Yeah. I think for a sporadic, as has been said, I think for a sporadic patient who has disease confined at the thyroid, not a lot of grossly apparent central compartment lymph nodes, I think we would certainly entertain unilateral.
Yeah. So I think for the audience, this is I think there's plenty of data. The Japanese have been doing this for a long time, but at least in the United States, this is a little cutting edge. So you definitely want to make sure you have really good imaging. You know what you're doing. It really is low risk and confined for that lobectomy. But I think the door is open. So if I take us back to this hypothetical case, which was lots of lymph nodes in the neck, where did you go on this one, Kate?
Okay, Sabrina, thank you. So this patient would proceed to surgery with a total thyroidectomy and a right neck dissection. Again, confidence from the radiology to suggest that wasn't anything pathological in the contralateral neck. Next click, please, Sabrina. So the histopathology showed multifocal medullary thyroid cancer. The largest lesion was on that right side at 50 millimeters, but there were some foci of sub-centimeter disease contralaterally as well. The lymph nodes were involved throughout the levels on the right neck, and into 6, but also superior 7. Next slide, please. Sorry, and next slide.
Hold there for me just a second. Go back one. Margie, help me out here. So in the medullary, what do I expect to see in the path report? What's changed over the last few years?
Sure. So what you really should be expecting is the grade. And so that's been championed by Ronnie and then validated internationally. And so it's really nicely broken down into high grade versus low grade. And, it's the general memorial, story, necrosis, mitotic activity. And so, grade is an important prognosticator here. We're going to assume that this is low grade because and we'll assume here that, if there was necrosis or mitotic activity, that would have been seen. So that's the real big change.
Yeah.
Now, in terms of the multifocality and that this is small volume disease, as been said before, it might, and far be it from me, I'm just a pathologist, but the multifocality in both lobes doesn't exactly justify the total, and this is a very common thing to see, in sporadic as well as in syndromic.
Right, because we know in papillary cancer it's often bilateral, and we do lobectomies on those guys all the time. So just bring it out so it doesn't freak people out, and that's like the reason to do a total. So I agree with you totally. Okay, and where'd you go on this one, Kate?
JP's got the hand up. I don't know whether that was.
I'm sorry, JP.
Yeah. So just a comment though. I will say that it's very important to make sure that there is. I mean, it's a young patient. It could be familiar. To rule out pheochromocytoma. That's for the audience in general. That is one of the things that the genetic test might take a while. You just run a testing in the urine and the blood just to make sure that you don't have a few also there.
Yeah, JP, that's a very important point. She's 35.
Yeah.
I think,
yeah. So it's unlikely that this is sporadic.
And from a practical aspect, JP, what do you do? I mean, these guys want to have surgery in 2 or 3 weeks. What do you do?
Yeah, you do blood testing for catecholamines. I mean, urine could also be done. It's 24-hour urine collection, so it's a little bit bothersome for patients. So you can start with blood. You get the results usually in 1 or 2 days. So that will fit into the time to surgery.
Perfect. All right. And I know it's Kate. She does molecular testing on, I won't say everything, but Kate's practice leans that way. So what'd you do, Kate?
Yeah, next slide, please. So, and just another click, please, Sabrina. So, interestingly, this example, the patient doesn't have a germline RET, but does have a somatic RET mutation. Next click, please. And 5 weeks following surgery, the calcitonin starts to fall nicely. So that's a very early time point to measure the calcitonin. You'd expect it to be continuing to fall at that point.
Hey, Mark, give me your read on that somatic 918 mutation. I mean, it often pops up in the bad distant metastasis, folks. I mean, you can see 634 in there, but any feel for it? Does that mean anything to you when you see that up front, Mark?
Yeah, I mean, this is these 918 mutations are considered more high risk. I mean, it doesn't necessarily always change or generally change how that patient is treated. There was a question in the chat which was about how you evaluate prophylactic thyroidectomy in RET positive individuals with family history of MEN, and then in those situations you do really take into account. Is this a low, moderate risk mutation or a high risk mutation? What's the patient age? How, have other families members with this particular mutation? How has their disease behaved? So there's a lot of information you can get from the particular mutations. But in this case, I'm not sure that it will change our management, but it is interesting.
Just a little more insight. Hey, Nicole, so the pre-op thyroid was 13,000. Kate, you was one of the great surgeons at Royal Marsden. It came down to 600. You surprised, not surprised? Did you expect it to go to 0? Sort of what expectations do you set with a patient before you send them off to the surgeon?
Yeah, I'm not expecting it to go to 0 anytime soon. I mean, it went down a lot, and And it's probably gonna go down further because it's a 5-week period. But I would be concerned of a distant metastatic disease from
Yeah.
the beginning.
So we dropped down nice. We had a ton of lymph nodes in the neck. I usually say surgeons are good, but they're not God. They can take out everything that they can see, but I would suspect she probably has some small volume lymph node metastasis hanging around with a calcitonin of 600. So what happened is I assume you just watched for now, Kate, and then what happened?
Yeah. If you can just click on Sabrina. So it continues to fall, and then again, please. But then just picked up a little bit. So there was just an uptick of the calcitonin. If you click again, please. Organized some imaging, and after the 6 months after the operation, we started to see some low volume but pathological lymph nodes, again within that same neck. So within the right neck, once again, contralateral neck remained clear. We organized for some imaging of the rest of the body. At that point, we did a contrast-enhanced CT with triple phase through the liver, and there were no other sites of disease. Confirmed that these small lymph nodes were actually pathological on FNA, and we identified active disease, viable disease within level 2 and 4 on that right neck. Next slide, please.
Hold on just a second. Go back one for me.
Yeah.
Dr. Shaha, I know you personally love it when I biopsy these little 8 by 3 millimeter lymph nodes.
Yeah.
And send them down to our shared clinic on Wednesday. What do you? I mean, talk to me here about this case.
Well, there are 2 points about this case. She came with a very high calcitonin and multiple positive nodes. We know we're not going to be biochemically curing this patient. I think that's the bottom line. The drop to 600 is admirable. Congratulations to the surgeons. But we know when there are 20 positive nodes, there is a 21 and 22 and 23 node. I wouldn't be in a rush to do the needle biopsy, partly because unless it is in a critical area, because the minute you do the needle biopsy and that is positive, the patient, family, and the neighbors are going to push you for another surgery.
Yeah.
That may not be the end of the second surgery. That may be inviting the third and the fourth and the fifth surgery. I would rather consolidate to make one surgery at the best time. So that would be my approach. This is the same analogy for papillary carcinoma.
Yeah. Nicole, I mean, to have this discussion with this is a young person, right? In their 20s or somewhere, 34 years old. And if they have the misfortune of seeing Dr. Shaha first and then come see me a few hours later, they say, Dr. Shaha told me he couldn't cure me. He also told me Dr. Erkin couldn't cure me. So that'll stop that consult. And then number 3, can't I make this go away? What are you telling me? I'm going to live the rest of my life with medullary cancer? How do you have that discussion with the patient?
Yeah, it's a tough discussion, but I would probably ask the patient what he understands is thyroid cancer, this type of thyroid cancer, and yeah, I'll probably tell him that he might not be biologically cured, but he might be without disease for a long time. Some things might pop up and might need treatment later on.
Yeah, absolutely. Mark, how do you think? I mean, you get these referrals all the time that they're persistent low-level disease in the medullary. You could find them if you wanted to. How do you make that decision about when do you keep watching? When do you have to do something? Think through that a little bit with me. Mark, go ahead, Mark.
Yeah, able to hear me?
Yep.
Yeah. So I completely agree with what Ashok said. I would definitely play the long game with this patient, understanding that this disease is not likely ever to be surgically curable. It's a difficult conversation, but it's important that you spend the time to go through that with the patient. Really, you need them to understand why. It's not that just you don't want to do surgery. It's been 6 months since the last surgery, so if you can put it out to a year, 2 years, 3 years, and kind of watch the disease for a while, it's if it's in a non-threatening location. I mean, some of these can double in size and not become a different surgery whatsoever. So I would definitely try to delay surgeries and play the long game on this particular patient. And some of these patients are going to manifest with distant disease at some point, structural distant disease. So then they're going to need systemic therapy anyway. So I think there's a lot of advantages to consolidating surgeries and playing the long game.
Mark Erkin, help me here, Mark.
Yeah, I just want to clarify something. Actually, on the door of my clinic, there is the motto, what Shaha can't cure, we can. And so it's actually everywhere in my clinic. It's printed everywhere. I just want to clarify.
And may I just ask, does the grading of the disease alter that sort of surgical decision now? So if you had a patient who'd had high grade disease and they recurred, or as opposed to low risk disease, would you have less inclination to go in if the disease was still localized? Or, you know, if it was low grade, would you think, well, we may still have a curative option here? I wondered if that influences the surgical decision now that we get grading of the disease.
Dr. Zafereo?
Yeah, I mean, I don't think I would change my. I would certainly keep it in the back of my mind. I don't think I would change my decision to act more quickly with surgery because of that. I would want to see the sort of biology, how the disease behaves over time, and also let that sort of dictate to me what the biology of the tumor is. Grade is certainly important, and it's one factor we use, but we'd also want to sort of look at growth rate over time and such to see, you know, how aggressive this disease and act when we need to. That initial thought.
And presumably the interval between relapses influences that as well. So, you know, if it was a rapid relapse, then you'd have less inclination perhaps than if someone had relapsed, you know, after a few years.
So we often, you know, me and checklists, right? Everything's a checklist. So our checklist is 5 things when we talk about what's detectable versus what's actionable, right? So we've detected stuff, what's actionable. And the 5 things are size of the tumor, location, because sometimes small things in bad locations need to be treated, right? Size, location, rate of change, which captures the biology, or PET scan telling me what the rate of change is going to be. Symptoms or development of symptoms in the future. And then the last one's patient preference. So we use size, location, rate of change, symptoms, and patient preference. And whether that's in the neck or the lungs or distant metastasis, that's a checklist we kind of go through. And I think that encompasses those factors you were talking about, right, Kate? Which is what is that interval, how rapidly they're coming back and not coming back.
And I presume that now, I'm sorry, but I realize that time's short. But the other question that I put this example in for is that now we also have effective RET inhibitors. I wondered if that shifts that threshold of decision for our surgical colleagues now in these situations. Because previously, you have recurrence within the neck and nothing distantly. You might think that surgery is the only option for control. But now we've got good, effective systemic therapies. I wondered if that changes that decision, whether that also comes into the checklist.
Yeah, Mark, talk about that a little bit, because you guys have been right at that forefront of systemic therapy and integration with surgery, that sort of stuff. How do you guys think about that neck and distant disease at the same time?
Yeah, I think that's an excellent point. I think it does sort of enter into the sort of the back of your mind discussion. I think for this particular patient, I mean, she's 34. I think she's, I think it was 34. Right? Yeah, she's relatively young, and you know that you've got that RET specific inhibitor in your back pocket, but until she manifests with distant disease and that structurally progressive distant disease, you're probably really not going to want to use it. You're probably going to want to try to maximize your surgical options in the neck to sort of stave off that systemic therapy for as long as possible, because again, you're playing the long game and trying to keep this patient going and for decades. And so I think you would want to consider it a surgical disease for as long as possible. And again, try to minimize your total number of surgeries as well.
Awesome. Dr. Erkin?
Yeah, so I guess the question is, for Mark, and if Ashok wants to weigh in, what is your threshold? Because as the patient comes back, calcitonin's rising, you're seeing progression, albeit probably small, but nonetheless, the patient's temperature and their family is going to continue to rise. So what's your trigger to say, let's go ahead and move forward here.
If the node is at level in the lateral neck, level 3, 4, 2, I'm very comfortable monitoring the patient unless the nodule becomes double the size. That would be my definite indication for surgery. Or it is clinically palpable. I think that is another thing that we never think about. If it is in the paratracheal area and I'm concerned, I'll be a little more aggressive in taking it out because I'm worried it may impinge on the trachea or the nerve. Now, if it is in the paratracheal area, the patient and the family need to understand either the tumor may kill the nerve or we may kill the nerve. And I think they need to be prepared for that. Again, the decision making in these cases is not one particular facet. Even though Mike alluded to 5 different aspects, it's just the discussion. And we are very fortunate here that we have somebody like Mike Tuttle who will discuss with us and then go to the patient and say, this is what we think about. And it is for him to convince the patient that you don't need surgery tomorrow is much easier than me as a surgeon.
Yeah. JP, let me bring you back in. I'll channel my inner Dr. Jayton Shaw. Hang out with those surgeons, and he'll often ask, "What's the goal of your surgery? Yeah, you can do this, but if you send this lady back, JP, what's the goal of your surgery? What are you trying to accomplish?"
So yeah, I think the probably the most important piece of all this is the initial conversation to have with the patients rather than the subsequent one. So when I talk to the patients, I usually tell them this is not curable. You will always have some degree of cancer, but it doesn't mean that you're gonna suffer from this cancer in the immediate future. We're gonna see things coming back, and we're gonna watch, and that's perfectly okay. And so in this instance, I don't see, for instance, the benefit of going through the surgical that lymph node. Now, the moment that you did the biopsy, probably you already crossed that, because you already are in a point that tell the patients, we did the biopsy, it's cancer, we're gonna watch. So that's a very difficult thing. I mean, you have been doing active surveillance. We know that some conversations don't go always that well. So this patient, if we were at that point, what I will do is perhaps just have a short follow-up period just to make sure it's not growing quickly, and offer even ethanol ablation if that's the case, just to as more a psychological treatment more than an oncologic treatment, because we are reducing the size of the tumor, we're making this go away. But having said that, this patient, it is possible that it's cooking more lymph nodes in that area. So I would expect that future ultrasound will reveal maybe something popping up, and maybe as has been said, a consolidated surgery within some period of time after.
Yeah. So if the goal of the surgery is to destroy one lymph node, then ablation's a reasonable thing, right?
Yeah.
That's not going to make calcitonin go away or that sort of stuff. So they're in that. Kate, in the last minute or so, let me take this like way down the road. It's never going to happen to this lady, but really the role of external beam radiation in medullary cancer. It's 20 years ago. Lots of these guys with their initial surgery were getting surgery and external beam radiation at Memorial and MD Anderson, and we seem like we've really rolled back on that. Ignoring this case, what's the role of external beam radiation in medullary as you see it now, Kate?
Yeah, well, that was exactly two of the points that I wanted to bring up was the fact that we've reined back in the surgery, but that's probably because of better staging. But equally with external beam radiotherapy, there's always been a lack of good data that external beam radiotherapy in the adjuvant setting improves survival rates. We have used it for control rates. And so potentially, if you've got disease that's somewhere that's critical, like up against the trachea, into the esophagus, where the surgeons say, I've got macroscopic disease remaining there, I'm worried that, that's when we still do consider external beam radiotherapy, but we have a much higher threshold to deliver it, especially in these young cases, where you've got a long period of time where they will live with potential morbidity from external beam. So I think you have to have a high threshold. And as with surgery, you have to say, what am I trying to achieve?
That's beautiful. Guys, we're right up against the time at 1 minute after. Kate and Leslie, thank you so much. These were great cases to talk through RET inhibitors and RET thyroid cancer. Thanks for Ashok and Mark letting us drag in. Appreciate that. Everybody have a wonderful time and fantastic job, panel. Great work.